Hello, welcome to the second session of the surgical postgraduate medical entrance test practice session. Similar sessions for concept bridge are telecast in YouTube. The channel address is given youtube.com/acpgmat. You can also log on to the Facebook account facebook.com/acpgmat. Please visit the channel regularly. Already 70 videos have been uploaded. You can also see the old videos. This is the second session. Already we discussed around 6 questions in the first session of the surgical practice session. That continuation is in this part. The seventh question: a 70-year-old man with aortic and mitral valve regurgitation undergoes an emergency sigmoid colectomy and endocolostomy for perforated diverticulitis. His postoperative course is complicated by a myocardial infarction and a atrial fibrillation. 4 weeks later, he has improved the clinical condition and requests elective colostomy closure. So what do you recommend? Discontinuation of the antiarrhythmic and antihypertensive medications on the morning of surgery. The second option is discontinuation of the beta blocking medication on the day prior to surgery. Then control of the congestive cardiac failure with the diuretics and digitalis in severe cases is the third option. The fourth option is administration of prophylactic antibiotics other than ampicillin and genta for patients with valvular heart disease who are undergoing gastrointestinal procedures. And the last option is postponement of elective surgery for 6 to 8 weeks after a subendocardial myocardial infarction. So which option is right? You can go back to the video if you want to see the options again. What is the answer? The answer is C, the third option. There are several recommended interventions in cardiac patients who are undergoing non-cardiac surgery. The two factors that correlate best with postoperative life-threatening or fatal cardiac complications are myocardial infarction, transmural or subendocardial, and uncontrolled congestive cardiac failure. Hence, delay of elective surgery for 6 months after myocardial infarction and pre-operative control of congestive cardiac failure, diuretics and digitalis in severe cases will have the greatest effect in decreasing the risk of surgery. The patient's cardiac medication would be continued preoperatively, including during the morning of surgery, to maintain adequate therapeutic level. This is especially true of beta blockers, which can manifest withdrawal, rebound, hypertension and tachycardia approximately 24 hours after discontinuation. Patients with prosthetic valves or valvular heart disease should be given prophylactic antibiotic to prevent the seeding of their valves during episode of significant bacteremia. This most commonly occurs during gastrointestinal or genitourinary procedures. Ampicillin and gentamicin cover the flora frequently encountered, including enterococci and gram-negative organism. The next question, read the clinical details. A previously healthy 55-year-old man undergoes elective right hemicolectomy for a Dukes A cancer of the rectum. Ceca. Cancer of the ceca. His postoperative ileus is somewhat prolonged, and on the 5th postoperative day, his nasogastric tube is still in place. Physical examination reveals diminished skin turgor, dry mucous membrane, orthostatic hypotension. Pertinent laboratory values are as follows: ABG shows pH 7.56, PO2 85, PCO2 50. Serum electrolyte sodium 132, potassium 3.1, chloride 80 and bicarb 42. Urinary electrolyte sodium 2, potassium 5 and chloride 6. There are two questions. The first question is: the values given above Allow the descriptive diagnosis of 5 options are given: uncompensated metabolic alkalosis, respiratory cirrhosis with metabolic compensation, combined metabolic and respiratory alkalosis, then metabolic alkalosis with respiratory compensation, or paradoxical metabolic respiratory alkalosis. Which option is right? Mark it. The answer is the D1, metabolic alkalosis with respiratory compensation. See, both the arterial pH and PCO2 are elevated in the patient presented in the question. The disturbance is alkalosis with hypoventilation. The PCO2 typically increases by 0.5 to 1 pKa for each milliequivalent per liter increase in serum bicarbonate. These findings suggest that the hypoventilation is compensatory rather than a primary phenomenon. This assumption is further supported by the absence of the clinical disease. The arterial blood gas study pH was 7.56 and PCO2 was 50 in this case. The second question, based on the clinical scenario, the most appropriate therapy for the patient described would be, 5 options are given: infusion of normal saline 0.9% with supplemental potassium chloride until clinical signs of volume depletion are eliminated, infusion of isotonic, that is 0.15 normal hydro HCl via a central venous catheter, clamping the nasogastric tube to prevent further acid loss, then administration of acetazolamide to promote renal excretion of bicarbonate, then intubation and controlled hypoventilation on a volume cycle ventilator to further increase the PCO2. So out of these 5 options, which one will you choose? Mark it. The option is number 1, that is infusion of saline. The development of a clinically significant metabolic alkalosis in a patient requires not only the loss of acid or addition of alkali, but renal response that maintain the alkalosis. The normal kidney can tremendously augment its excretion of acid or alkali in response to changes in ingested load. However, in presence of significant volume depletion and consequent excessive salt and water retention, the tubular maximum for bicarbonate reabsorption is increased. Correction of volume depletion alone is usually sufficient to correct the alkalosis, since the kidney will then excrete the excess bicarbonate. HCl infusion is usually unnecessary and can be dangerous. Acetazolamide is unlikely to be effective in the face of distal sodium reabsorption in exchange for hydrogen secretion. Moreover, to the extent that acetazolamide causes natriuresis, which will exacerbate the volume depletion. The case history is to be listened to. A 23-year-old woman is brought to the emergency room from a halfway house where she apparently swallowed a handful of pills. Patient complains of shortness of breath and tinnitus, refuses to identify the pills she ingested. Pertinent laboratory values are as follows: ABG pH 7.45, PO2 126, PCO2 12, serum electrolyte sodium 138, potassium 4.8, chloride 102, bicarb 8. So she is probably on a mission to die. The first question based on this clinical scenario is: the patient's acid-base disturbance is best characterized by which the following descriptions? 5 options are given: acute respiratory alkalosis compensated, chronic respiratory alkalosis compensated, metabolic acidosis compensated, mixed metabolic acidosis and respiratory alkalosis, or mixed metabolic acidosis and respiratory acidosis. Choose the right option. That is the mixed metabolic acidosis and respiratory alkalosis. The patient presented in the question is in a state of metabolic acidosis, as shown by the markedly increased anion gap of 28 milliequivalent unmeasured anions per liter of plasma. However, the respiratory response is greater than can be explained by the compensatory response, since the patient is mildly alkalemic. The disturbance cannot be pure respiratory alkalosis, since the serum bicarb does not drop below 15 milliequivalent as a result of renal compensation, and the anion gap does not vary by more than 1-2 milliequivalent per liter from its normal value of 12 in response to respiratory disturbance. The renal response to hyperventilation involves wasting of bicarb and compensatory retention of chloride. It does not involve change in concentration of unmeasured anions such as albumin and organic acid. The second question, based on the clinical scenario, the most likely cause of the disturbance in this patient is an overdose of which of the following 5 options: fenformin, aspirin, barbiturate, methanol, or diazepam or Valium. Which one she took for committing suicide? So the correct answer is aspirin. The acid-base disturbance in the patient described in the previous question demonstrates the value of extracting all valuable information from a small amount of rapidly retrievable data like RT-ABG. Salicylates directly stimulate the respiratory center and produce respiratory alkalosis. By building up an accumulation of organic acid, salicylates also produce a concomitant metabolic acidosis. Characteristically, both disturbances exist simultaneously following massive ingestion of the salicylate. If sedative agent have been taken as well, respiratory alkalosis and even respiratory compensation may be absent. The fenformin and methanol overdose also produce high anion gap metabolic acidosis but without simultaneous respiratory disturbance. In the case presented, the patient's history of tinnitus in conjunction with her mixed metabolic acidosis, respiratory alkalosis, is essentially pathognomonic of salicylate intoxication. The next question, 65-year-old man undergoes a technically difficult abdominal perineal resection for a rectal cancer during which he receives 3 units of packed red blood cells. 4 hours later in the intensive care unit, he is bleeding heavily from his perineal wound. Emergency coagulation studies reveal normal prothrombin, partial thromboplastin and bleeding times. The fibrin degradation products are not elevated but the serum fibrinogen content is depressed and the platelet count is 70,000, most likely cause of the bleeding. The options are 5. Delayed blood transfusion reaction, autoimmune fibrinolysis, a bleeding blood vessel in the surgical field, factor 8 deficiency, hypothermic coagulopathy. You can go back to the case history and then try to answer the question by pausing and rewinding and play forward. The answer is bleeding blood vessel in the surgical field. Whenever significant bleeding is noted in the early postoperative period, the presumption should always be that it is due to an error in surgical control of blood vessel in the operative field. Hematologic disorders that are not apparent during the long operation are most unlikely to surface as problems postoperatively, and blood transfusion reactions can cause diffuse loss of clot integrity. The sudden appearance of diffuse bleeding during an operation may be the only evidence of an intraoperative transfusion reaction. In the postoperative period, the transfusion reactions usually present as unexplained fever, apprehension and headache, all symptoms difficult to interpret in the early postoperative period. Factor 8 deficiency would almost certainly be known by the history in a 65-year-old man, but if not, intraoperative bleeding would have been a problem earlier in this operation. Severely hypothermic patients will not be able to form clots effectively, but clot dissolution does not occur. Care should be taken to prevent the development of hypothermia during long operation through the use of warmed intravenous fluid, gas humidifier and insulated skin barrier. Hope the session was useful to you. Next session will be uploaded in the ACPGMed in the YouTube. You can also see similar sessions in the same channel, youtube.com/ACPGMed. Thank you.